And today's topic is thoracic wall blocks. I am Dr. Senthil Kumar. I work as a consultant anesthesiologist in Ganga Medical Center and Hospitals, Coimbatore. It's a pleasure to be a part of this program. I thank Johnny and team for giving me this opportunity. Let's go to the topic. Today's topic is thoracic wall blocks. Why you need thoracic wall blocks? We have epidural, we have paravertebral. Why we need thoracic blocks? It gives you perioperative analgesia for breast surgery, traumatic rib fractures, analgesia for thoracotomy, video-assisted thoracoscopic surgery, sternotomy, chest tube placement, and pacemaker insertion. Let's see what is the anatomy of the chest wall. It consists of skin and subcutaneous and glands such as breast and other lymph nodes. The main major muscle behind the skin and subcutaneous tissue on the glands is the pectoralis major. Then comes your pectoralis minor. Then comes your serratus anterior. Then your rib cage and your intercostal muscles. How do these chest wall blocks or thoracic wall blocks act? They mainly act by passive spread of local anesthetic to the nerves traveling within the tissue or adjacent tissue brain compartments. What are the advantages of thoracic wall blocks when compared with the paravertebral and epidural thoracic epidurals? It's very easy to perform. It's relatively very safe. Adverse complications such as spinal cord injury, epidural hematoma, nerve injury, pleural puncture, and lung injury is least with your thoracic wall blocks. Hypotension induced after an epidural or a paravertebral is nil with thoracic wall blocks, and patient satisfaction is good with thoracic wall blocks. Let's see what is the innervation of the thoracic wall. The sensory innervation is mainly by your intercostal muscles, intercostal nerve with the branches with lateral and anterior cutaneous branches. It supplies the whole of the thoracic cage. But superiorly, it also gets branches from your supraclavicular nerves that in turn emerge from your suprautial cervical plexus. It also gets muscular branches from the brachial plexus, such as lateral and medial pectoral nerve, thoracodorsal nerve, and long thoracic nerve. The cutaneous innervation is mainly from your intercostal nerves, from T1 to T6. Each intercostal nerve in turn divides into lateral and medial cutaneous nerve. The chest wall also gets supply from the intercostobrachial nerve and also the supraclavicular nerves superiorly. It also gets innervation from the muscular branches from the brachial plexus, such as lateral pectoral nerve, medial pectoral nerve, long thoracic nerve, and thoracodorsal nerve. Why these nerves are very important when you do chest wall surgeries? Because the myofascial pain that is due to the disruption, stretching, or spasm of the pectoral muscles or fascia will lead to chronic chest wall or thoracic pain. So, unless and until you block these nerves, or if these nerves are not blocked, it can lead to chronic pain post-surgically. Let's first know about the typical intercostal nerve. What is its course and its anatomy? The ventral and the dorsal rami of the typical thoracic nerve emerges from the intervertebral foramen. Then the ventral rami travels into the paravertebral space and then leaves the paravertebral space and enters the chest wall cavity, where it is named as intercostal nerve. It travels between the innermost intercostal muscle and the internal intercostal muscle. At the angle of the rib, it gives off the lateral cutaneous branch, which in turn divides into anterior and posterior branches to supply the lateral half of your chest wall. The same intercostal nerve travels anteriorly, and in the parasternal region, it gives out the anterior cutaneous branch, which in turn branches into lateral and medial branches. Then these are the various sites where you can block the intercostal nerve, and accordingly they have been named. Posteriorly, it can be blocked at the erector spinae plane or in the paravertebral region, paraspinally at the wrist, or laterally or anterolaterally, you can block it at the pex plane or serratus plane, and anteriorly, it can be blocked between the pectointercostal plane. Accordingly, each of these blocks are named. As with any blocks, it should be done under sterile aseptic precautions with everything, all emergency drugs ready, monitoring ready. These chest wall blocks can be mostly done with high frequency linear probe, or sometimes in obese patients we might require a low frequency curve linear probe. Thoracic wall blocks, let's move from posterior to the anterior. Posteriorly, they can be given at erector spinae plane block or retrolaminar block, midpoint transverse process to pleura block, intertransverse block. Let's see each one of them. Erector spinae block is the most commonly performed block nowadays because it has revolutionized the thoracic wall surgery. As it is placed between the erector spinae muscle and your transverse process. It's very important to how you identify your transverse process. It's usually performed with the patient either in the sitting, lateral or in the prone position. For chest wall, it can be performed usually at the thoracic level T4, T5 or T6 and to T8 level. The transducer can be placed either parasagittally or transverse orientation. We need a 22 gauge 50 or 100 millimeter short bevel needle, and direction of needle insertion can be cranial to caudal or caudal to cranial in plane or into lateral to medial. We usually need about, in a single shot block, 20 to 30 ml of 0.25% bupivacaine or 0.375% ropivacaine. If you are putting in a catheter, then you can maintain an infusion rate of about 8 to 10 ml per hour. While we are doing scanning for the erector spinae block, the main aim is to identify the transverse process. We put the probe parasagittally in the midline over the spine. Initially, we identify the spinous process. Move laterally, we identify the lamina, and much further laterally, you identify the transverse process, which has a squarish top end appearance and three muscles that are arranged above the transverse process, that is trapezius, rhomboid, and erector spinae muscle. You further move laterally, you get the rib. You have to differentiate between the transverse process and the rib. The transverse process usually has a squarish top, while the rib has a rounded appearance over the top. So this helps you to identify the transverse process from the rib. The main aim is to bring in the needle, hit the transverse process, and deposit the drug. As you are injecting the drug, the erector spinae muscle as a whole should be lifted up, and you have to visualize the cranial and caudal spread of the local anesthetic. What are the complications of this block? It could be a block failure. That could be an intramuscular injection that you have to be very careful. Pneumothorax, local anesthetic systemic toxicity, and epidural spread and hypotension. This is the zona anatomy of the erector spinae plane block. You can see the skin, subcutaneous tissue, and the three muscles, trapezius, rhomboids, erector spinae, and you can see the transverse process with the hyperechoic line with the shadow beneath it. You bring in the needle from caudal to cranial, hit the transverse process, and then inject the drug. In this video, you can see the proper placement of the needle and the proper administration of the drug. Here, you can see the needle coming in plane. You can see the transverse process with the hyperechoic shadow, flattened top. You can see the three muscles. As you inject, you can see in this video, the needle is initially the needle is not in proper position. There is an intramuscular injection. Again, this needle is manipulated and moved further, where you can see the correct deposition of drug in the plane, where you can see the erector spinae muscle is moving up and there is craniocaudal spread of your local anesthetic.